I hope I won't depress you excessively as a result of today's presentation, although there are some depressing statistics to talk about when we talk about healthcare. Just to give you a very brief background on General Dynamics Information Technology, we're a very large provider of health technology and information services, primarily to the United States government. So we do a lot of work for the Center for Medicare and Medicaid Services, and a lot of other federal agencies. We're also starting to do some work in the United Kingdom, and we're branching out into other places as well. So our role is as a systems integrator. We're not primarily a vendor of products, so we have a little bit of that. We're primarily focused on taking the health capabilities of organizations and combining them in new and interesting and better ways so they can solve the problems that they're experiencing for their constituents. So I'll talk a little bit about our perspective from a big picture about where the challenges are with our health system in the United States, some of the interesting characteristics about those challenges, and some areas where we're seeing opportunity for innovation that we're starting to invest in and explore that seem to sort of align with some of the discussion we've had earlier here today. So some of the key challenges. The first is basically how expensive is healthcare in the United States? Well, just some basic statistics. It's almost out of every $5 in the economy now is associated with healthcare. Spending is now about $2.6 trillion plus. The insurance premiums have gone up by a factor of more than 2 over the last decade or so. So clearly the numbers are extraordinary. And if you compare what we're paying to what other countries are paying for healthcare and what the cost curve looks like, this is literally the United States healthcare cost curve since 1970. And you can see that it's skyrocketed up to close to $8,000 a person, which is more than double than almost any other industrialized nation for healthcare. So we're spending a lot of money in healthcare. This comes from an organization called the OECD. Another OECD statistic to look at to sort of use as a benchmark is, what does it look like per individual country? The average is about $3,200. As of 2010, the United States was spending about $8,000 per person on healthcare, which you could argue may be a justifiable investment if we were getting commensurate returns in terms of quality and coverage of the population for that type of investment. But the numbers we're seeing don't look like that. A study that came out from the Institute of Medicine last year said that basically the United States wastes about 1 in every $3 on healthcare. So out of that $2.6 trillion, roughly $750 billion is essentially waste. It's money that could be better spent elsewhere. It's based on services that aren't needed, services that are delivered inefficiently, extraordinary administrative costs compared to other industrialized nations for the administration of healthcare. You've probably seen a lot of the statistics that come lately around the price of healthcare in the United States for individual services compared to other countries, whether it's hip replacements or other types of services. Often they're greater than other jurisdictions by a factor of 10 or more. And even in the United States, HHS came out with a study just a couple months ago that made a lot of hospital data freely available. And they would show that 2 hospitals that are geographically proximate to each other could provide exactly the same service, a medical procedure of some kind, and the difference in cost could be by a factor of 10 or more. Right? Those are day-to-day realities that patients in the United States face today. I know I'm preaching to the choir here, so I won't get on my soapbox excessively about that, but those are extraordinary numbers. That's a system that is broken in fundamental ways by almost anybody's account.
Is there any other product in this country where you see this kind of behavior? Pricing?
I honestly can't think of one. I mean, in most industries, you think
education, right?
I guess I'm not really sure why that's so shocking. When that data came out, that CMS released the data, and they did the New York Times did a report and showed the map, and they said if you go down the 10 blocks down the road, you pay 10 times more. If you go to Joe Schmo law firm and ask them to file a complaint for you, you might pay $1,000. If you go to DLA Piper, you're going to get the same complaint, and you're going to pay $10,000. You might get better service, right? Same thing here. If you go to a random hospital, rural community clinic, and you want, the top of the line cardiac surgery, you may pay more, you may pay less, you may get the best service, you may not, versus you go to Johns Hopkins or MedStar or whatever. So I guess I'm all for lowering the cost of healthcare, but I'm not sure that data that was produced, it was very I looked at the data, I looked at the the spreadsheet, and it wasn't very informative to help us understand whether there really is, whether that particular example really is a problem or not.
Well, there are two things about healthcare that I think are notable in that respect. You're right, there's price variation in any industry. That's certainly true. The two things I think that are characteristic of healthcare is their significant lack of price transparency. It's hard to know how much two different hospitals charge for a given procedure. And of course, you as a consumer have considerably less bargaining power over the cost of your care than you do for many other industries. You know, you can ask a law firm ahead of time how much it'll cost them to draft your will, and you get a reasonably good estimate of that, and you can, as you said, compare two different law firms and decide which one you want, or you can decide not to use either of them. You know, if you need a medical procedure, you need it, but it's unlikely the medical facility can give you any kind of meaningful price estimation of that cost ahead of time. And I honestly don't want to spend a lot of time today engaged in philosophical debates about the nature of the system, other than to point out that these are significant challenges. These are issues that need to be addressed in one capacity or another. The other thing, though, is, you know, you'd say, well, if we spent twice as much as every other country for healthcare, but we got results that were twice as good, you could argue that's a rational investment. But it's hard to make that case in the United States. You know, study after study shows the United States often lags and is close to the bottom of other industrialized nations for a lot of fundamental measures of population health. Life expectancy to age 50, right? America is worst among 18 industrialized countries for men and second worst for women. That study just came out a few months ago. Hospital readmissions, specific disease and things like that. There are areas of excellence. I don't want to paint American healthcare with a broad brush and say there's no great care going on. Of course there is. But we're paying a lot of money for inconsistent levels of care and often leaving significant portions of the population uncovered. Whatever your political affinities may be, I think most people would argue there must be a better way to address those. And the question is, some of those things are fundamentally policy issues that are, you know, beyond the ken of technology firms like GD or others to address. But there are opportunities for innovation to tackle parts of that I think could make a difference. That's really what I wanted to focus on today. The two things that I find most striking about the cost of care in the United States and the quality issues are around distribution. The first is around the fact that chronic disease is where most of the cost is. There was a bank robber in the 1930s named Willie Sutton. He was once interviewed and he was asked why he robbed banks. He says, because that's where the money is, right? Well, in healthcare, 3/4 of the cost of healthcare and 3/4 of mortality, according to CDC, is chronic disease, often with significant preventable behavioral components associated with it, right? If you sort of follow the current trend lines, according to the CDC, by midway through this century, 1 in every 3 Americans is going to be a diabetic. Right? Those are fairly dire numbers. You can see other numbers are associated with obesity. Almost half of all Americans have one kind of chronic illness. So if you're going to tackle the cost of care in the United States, tackling chronic disease seems to be key to that, since that's where most of the money and most of the mortality occurs. The other factor that I find fascinating about American healthcare is how the costs are distributed. AHRQ came up with a study last year that showed 5% of the population are responsible for roughly half the costs. Physicians I've talked to actually call it the 550 rule, right? 5% of the cost is 50% of the resource utilization. 1% of the population is 20% of the resource utilization, right? Those are extraordinarily skewed statistics or numbers. So an interesting question is, what could you do to prevent those 5% from ever becoming the 5% to address the cost of care in the United States? That strikes me as being one of the most interesting opportunities in terms of healthcare reform in the United States. Leaving aside, you know, opportunities to change policy or technology, the opportunity to look at that sort of typically complex high-needs population as a focal area for reform and improvement strikes me as being very promising. So what can you do in light of those specific challenges? Well, one of them that we see a real opportunity around is coordinated care. And so if you're familiar with some of the discussion that's taking place around organizations like accountable care organizations or patient-centered medical homes or things like that, they seem to be a good way to look at tackling the problems associated with complex, high-need patient populations. Essentially what you're trying to do is move away from reactive and isolated models of care to proactive and coordinated models of care. Or to put it another way, if the diabetic is showing up in your emergency room because their glucose levels have spiked, you've already lost if you're the healthcare provider, if you're the healthcare payer, right? You win if they're self-treating themselves at home proactively and you're monitoring them remotely, right? But that's a different model of care and a different model of reimbursement and incentive than the one we have typically seen in the United States healthcare system, although that is beginning to change. And so there's some specific technologies you can utilize to support that. Health information exchange is a component of that, medical homes, care coordination, ACOs, and things like that. I think information exchange is key to that because if you're going to have coordinated care, you have to have electronic medical records from all those places that patients are seen, so you can sort of look at that information and coordinate the care across care settings using care coaches or coordinators or other entities. We're doing some work in that space now ourselves. We see a lot of promise there. Another way of looking at it, there's a book I read that I really like called Innovators Prescription. I don't know if any of you have read that or not, but I highly recommend it. It's by Clayton Christensen and a couple other folks. And Clayton Christensen is really the father of models of disruptive innovation theory in the United States. And one of the points he makes is often care is delivered in the most expensive setting, which is a hospital, from the most expensive provider, who's a physician. But for routine care where treatment pathways are well understood, often it can be better administered by less expensive providers in less expensive settings, and ultimately administered in home settings or through self-care. So we see a lot of opportunities to do that, particularly with respect to chronic disease. Obviously, there are conditions that are not amenable to that kind of model, but many of them, particularly associated with chronic disease, we think are. Remote monitoring, consultation, telehealth, mobile platforms such as diabetes disease coaching and things are components of that. Use of social networks, like patients like us, patients like me, and things like that. And then from a policy perspective, giving increased autonomy to non-physician care providers and clinicians seems to be a component of addressing the cost curve as well. Another area that we notice there's a lot of opportunity to bend the cost curve in healthcare. This is an area where GDIT does a lot of work in our offices in Towson, is to develop solutions around what are called improper payments or program integrity, or more generally fraud, waste, and abuse in healthcare. Depending on which study you read and who you talk to, fraud eats up somewhere between 3 and 10% of the United States healthcare budget. In 2010, it chewed up about roughly $80 billion from CMS alone for Medicare and Medicaid for what they call improper payments. That's a lot of money. That's a lot of money that could be better directed to other aspects of care. The challenge is there isn't just one type of fraud in healthcare. There's really three. There's identity fraud, where one of the parties to the transaction, such as the doctor, the patient, or the processor, doesn't exist. They're imposters. There are transactional frauds where the doctor may be real and the patient may be real, but the procedure either was not performed or should not have been performed. Right? That's often called in the category of what people call waste or abuse. And then there are instances where an individual instance might be a case where the doctor is real, the patient's real, and the procedure is plausible. But collectively, the fact that patient received 10 oxycodone prescriptions that month, maybe not so plausible. Right? That's collusive fraud, where typically doctors and pharmacies and perhaps the patients are all colluding to defraud healthcare payers or other entities. And you need different types of solutions for all of those. You also need to find a way to move away from the traditional model, which is what's called pay and chase, where you pay the claim and then try and recover the funds later, to models where you're trying to essentially detect and deny payment for those claims ahead of time. That's exactly what the credit card industry did about a decade ago, and they significantly cut their financial losses by a factor of about 3 by being able to sort of move towards those sort of models. So GDIT has produced a whole suite of software solutions that are focused on fraud, waste, and abuse. I won't use this time to promote our solutions, but that's something where we see a real opportunity to make a difference.
Can I ask a quick question about that? Because this from sequestration or whatever, CMS just laying off. There were 1,300 cases that were reported by whistleblowers, and they declined to investigate or prosecute due to the no resources to investigate the cases. So that's just recently 1,300 cases of some of which probably was FWD that is now continuing to happen in the system. What specifically has the government bought a platform that you just described in that previous slide that is generating an ROI?
They've invested in multiple solutions for the detection.
Are they working? Is it being measured? Are we wasting money on that too?
I'm not sure I can answer that question. Well, first of all, I should be careful. Since CMS is a client of ours, it wouldn't be appropriate for me to speak on CMS's behalf about this. What I can say, I think fairly, is they've invested in multiple solutions for fraud. Some of them are showing greater return on investment than others. There's a widespread recognition that traditional approaches to sort of pay and chase models of fraud, which is all about sort of recovery after the fact, are inefficient and expensive. And that different ways of approaching fraud, whether it's prepayment or something else, need to be examined. Beyond that, I should be careful that I don't try and speak on behalf
Right,
of CMS.
Okay.
But I see that as being, and I'm not speaking about CMS here, for any payer. This could include the Blues or other commercial payers, other entities, or Medicaid entities. And they're facing the same challenges. This isn't unique to CMS. I think there's a lot of opportunities to use the integration of clinical data that you can get from Health Information Exchange into these types of investigations in ways that haven't been done in the past. Typically speaking, fraud investigations have been just focused on looking at the claim record, right, which is a pretty minimal view of the patient encounter. There's a lot more data in the clinical records that could be incorporated to better understand the nature of the transaction between the patient and the physician, to understand whether fraudulent behavior is taking place. And tools like big data will really, or approaches like big data will really help us to identify that. And I really see data as being sort of central to what we're trying to accomplish in healthcare. So fraud is one of the aspects that we're trying to address, but there are other things such as comparative effectiveness, pop health, chronic disease management, and clinical decision support that can really come from a lot of different sources. I think this is partly why we're moving into a golden age of health data, because traditionally the only electronic health data, if it existed at all, was claims data, right, which was used for reimbursement by insurance companies, right? But now with the rise of the meaningful use provisions for electronic health records, the advent of Health Information Exchange and things like that, there's access to other sources of data like clinical data, quality reporting data. That's an area where GDIT does a lot of work for CMS and other entities, where you're providing quality reports about not just what was done, but the kind of outcomes that were achieved. And as we move away from pure fee-for-service models of care towards some kind of pay-for-performance or pay-for-quality model of care, this will become increasingly important. But there's also research data, public records, and so on. They're all sort of good candidates for analytic solutions. This is an area where GDIT does a lot of work. For example, we helped to develop a solution that CMS utilizes called the Chronic Condition Warehouse that maintains massive quantities of health data over the last decade for Medicare and Medicaid recipients that's precisely used to identify what are the trends in chronic disease and what can you do to identify better interventions to address them. So we see a lot of opportunity there. All of that really is a way to sort of talk more generally about where the healthcare system I think can evolve to, and sort of one phrase we often hear coming up in this context I think is meaningful in the context of innovation opportunity for all of you here, is the idea of what people are calling a learning health system. I don't know if many of you ever sort of, I may be dating myself here, bought cars back in the 1970s or early 1980s. You had like a 73 Pinto or 75 Vega or something like that, right? You were lucky if you could get 3 years out of that puppy on the road, right? AMC Gremlin, or God knows what, right? Right? Not a lot of quality there, right? That wasn't really a focus. And then the Japanese came in, right? Honda came in, Toyota came in, these other organizations, and really started eating up their market share because they had a consistent and disciplined approach to continuous improvement of quality of their product, right? I think healthcare is on the cusp of exactly the same revolution, which is basically how do you consistently apply tools and methodologies to continuously improve the quality of the product, which in this case is healthcare delivery, right? And so the Institute of Medicine came up with a study on this a couple years ago called the Learning Health System. I know some of the folks who are involved in this, and I really see this as being an opportunity. And the best way to think about it is from a data perspective, with the advent of EHRs and HIE and other things, there are new opportunities to collect and manage health data, to exchange that data seamlessly across organizational boundaries as things like the Nationwide Health Information Network, now called eHealth Exchange, or the Direct Project, or some other initiatives can support. The use of analytic tools to really understand health data. And then I think the real payoff is when you sort of learn insights about the health system from using analytic tools, how can you use things like clinical decision support and other tools to feed those insights back into frontline care? I think that's really where a lot of opportunity lies. If you look at where a lot of the focus around health technology and investment is today, it's really here and here. I think the future is here and here. I think there's going to be a lot of opportunity and market space for innovation in those areas because of the cost pressures and the quality pressures we're seeing in the healthcare system. This is one organization's perspective. I'm sure you may hear a different variant of the story from other companies you might talk to, but this has been borne out by our experience in working on a fairly large scale with health agencies in the United States. Any questions?
The data that you showed before, was it all primarily Medicare data that you had access to in terms of feeding your analytics platform?
For the Chronic Condition Warehouse project, it is, absolutely.
So how do you get that data from other insurers and payers that are keeping it? That's part of the problem, right? Because you can't you're limited to the data set that Medicare has.
Sure.
And, you know, Aetna and some of the other companies have sort of created these APIs, but they're limited to what you can access through CarePass and things like that.
Mm-hmm.
So how do you see that changing?
You know, that's an interesting question. There isn't really a single national repository of health data across all payers. Some states have them. They call them multi-payer claims database or all-payer claims databases. So you see some of that occurring at the state level. I haven't seen the equivalent of an NPCD really that fully addresses this across all the jurisdictions today, although CMS is doing some work in that space. But I think there's a real opportunity there to figure out how we could look at those larger aggregate data sets and identify trends and patterns in them. Whenever you do that, you have to be careful to worry about issues around data de-identification and things like that, so you're honoring patient privacy and consent concerns with respect to the use of their data. But I think there's going to be significant opportunities around organizations that can take data from those multiple sources, synthesize them, and create some sort of unified platform that analytics can be run against. I think
The reason I'm asking is the most recent one was, did you hear about this article that the LA Times did where they're trying to request prescription data from prescribers, and they had to do a freedom of information request, and they were still not given access to what IMS sells, right?
right.
Yeah, I mean, I guess that, to clarify, do you get your data through your existing relationship with CMS, or is that a publicly available database? Because I think CMS does not publish the vast majority of the information that they have available.
They publish some of the data from CCW. In fact, they have a publicly available website. It's ccwdata.org. And I encourage you to go visit it. And you can see really interesting information there about breakdowns of readmission statistics and other information about patient populations, by demographic factors or geography and things like that. That's built, based on solutions we've developed for them. Not all the data in CCW is publicly available because of concerns around patient privacy and things like that. But they make a lot of it available for researchers for precisely these types of purposes. But you're right, that just represents one data set, Medicare and Medicaid. Of course, there are other data sets for other populations that would need to be ultimately integrated to get a complete picture of national health better than we have today. I'd be the first to agree with that.
Well, when I started off, I said all of you guys are involved in the learning process, and thank you for bringing the learning healthcare on, because that really validates my observation. And, this has been really cool. I thought this is my favorite meetup so far. I'm a science person, and I hope got an appreciation for how complex this is. But I'm hopeful that there are some smart people trying to tackle this. So, if anyone has any other questions, thank you very much for coming, and thank you for Howard County for having us here.
It's pretty interesting.
I do.
How does the system work?